made significant progress, going from 15, 16% 5-year survival rates with azacitidine decitabine in the last 2 decades to now 45, 50% long-term survival rates with the addition of venetoclax to the azacitidine decitabine. Similar progress has been seen with the low-dose cytarabine venetoclax that is being extensively used in Australia and Europe. But at the end of the day, we're still talking about 40 to 45% long-term survival rates. So the majority of patients are still going to either relapse or be refractory and not achieve a response over the 3 to 5 year follow-up period. So our big areas of research interest now at MD Anderson, in collaboration with a lot of academic centers across the country, has been to identify who are those patients who are either not going to respond to the hypomethylating agent venetoclax or relapse early. And I think we have a good idea about this, and a lot of this data is being presented this year and next year at some of the large national meetings. In general, we see patients who have TP53 mutations are either resistant, or even if they achieve a response to hypomethylating agent venetoclax, the response is short and they relapse. So we don't feel that this is the solution for those patients. For the TP53 mutated patients, we're still looking for new approaches, and one of those that has shown very promising activity is a drug called APR. This is a TP53 directed therapy, and the combination of azacitidine and APR has shown response rates greater than 90%, which has led to a phase 3 registrational study of this drug in MDS, but if it is positive, will also be probably beneficial and used in AML. The other approach that we're looking at for TP53 mutated are using immunotherapies, which have been very successful in many solid tumors and lymphoma and are being developed in AML. And we do see that there are certain immunotherapies such as CD47 antibody, which is a macrophage checkpoint directed therapy that, again, in some early phase 1b data has shown high response rates in newly diagnosed AML and TP53 when the azacitidine was combined with the CD47. So now we're looking at if it is possible to add drugs like the APR or CD47 to the backbone of azacitidine venetoclax to push not only the response rates, but more important, the durability as well as survival. And I think a lot of these studies will be done and presented next year. The other group where there is still unmet need is FLT3 mutated. We do see that these patients respond initially to the azacitidine venetoclax, but the response duration is short, and the median survival is 10 to 12 months for newly diagnosed FLT3 mutated patients with azacitidine venetoclax. So we are now combining venetoclax with FLT3 inhibitors, such as venetoclax with gilteritinib, venetoclax with quizartinib, and then even moving frontline, doing triplet combination of azacitidine venetoclax with gilteritinib or azacitidine venetoclax with quizartinib. And we are seeing, and it will be presented at the ASH meeting in 2019 this year, that the combination of venetoclax gilteritinib is very, very active. The response rate in relapsed FLT3 AML is about 85%, whereas single agent gilteritinib would give you about 45, 50%. So it looks like the doublet is very active, doubles response rate, and in general is very well tolerated. Of course, as we do these strategies, we have to be aware of the myelosuppression, and we have to build in interruptions, use of growth factors, and that's the reason all of these should be done in trials, because I think if we just try to add 1 + 1 + 1, the myelosuppression would be prohibitive and probably lead to high early mortality. So I think a lot of these trials will guide the way as to how we deliver these doublets and triplets in the best way so that we can increase efficacy while maintaining the safety profile.